Good morning, good afternoon, good evening. And I would say this is a really special session, at least for me, to be connected across so many time zones. And I congratulate the IUSSP for really organizing this wonderful conference. What a fantastic program. And to do it across time zones and huge range of topics. It's really a feast. So I want to welcome participants. This is, of course, the first day of the technical sessions, and we are encountering some minor logistic challenges, mostly coming from our side, the challenges of logging on, etc. But I hope these will all be ironed out, and that at least starting from the sessions today, this evening, that they'll all be well attended, lively sessions. The incoming president, or the current vice president and incoming president, Dr. Shireen Gigi Boy, had set up this session. It's an invited session on, I think, an extremely important topic, central, to what happened to us in the last 2 years and why we're having this huge conference that we used to look forward to, in a hybrid form. And we are connecting through computers, whereas we love, as you know, IUCSP members look forward to meeting up every 4 years. But this deadly virus and its various forms and its various rounds have had a huge impact on reproductive health outcomes, on contraceptive and abortion services. This was meant to be a shorter session of about 45 minutes to 1 hour. If there is extensive interest, we will go on beyond an hour. Otherwise, though we are timed, we have a time slot which is standard for 1.5 hours. We don't have to actually stretch it. We have two excellent panelists. But just before I introduce them, I just want to say by a few words of introduction that the impact of COVID-19 and disruption in services in countries with strong health systems like Britain and Europe and the Far East was, the impact was bad enough. But those most affected were the more fragile health systems, such as in the LMICs, that were weak and fragile to begin with and just collapsed under the strain of this deadly virus and its impact. So I think that now we see that health systems have regeared themselves, but at that time they were overutilized. Round-the-clock treatment was happening of major serious COVID-19 cases with huge issues of contagion. I mean, you had to have special wards, etc. So OPD, where most of contraceptive and abortion services are made available both in the public and private sector, were clearly either minimized or not available at all. And in the beginning, at least, I mean, there's been a lot of movement to include RH services since then and essential services. But initially, I think in most places, they were regarded as non-essential and not prioritized, even when surgeries, etc., were beginning to be allowed. So public sector services, particularly, I think, were more hard hit. But even the private sector, I think, took a huge load of responsibility for care of COVID. And so it really didn't offer, the private sector wasn't particularly a real option or a backup for the services that we are concerned about, that we're looking at in this session. I would say that the real absence, the real hit was the shortage of healthcare providers who were themselves publicly pleading for greater precautions. They themselves were worried about getting the virus, they were worried about PPE, and really pleaded for mercy. And many, at least where I live in Pakistan, they came on television and pleaded for mercy. So undoubtedly, there have been disruption in services. Supply chains, that's another, they were affected, maybe not immediately, but soon after, where products such as contraceptive products, health products really got caught up in the supply chain. And I think we see the ripple of those effects even in the medium and long run. But I think another important reason for the break in services were women and families that restricted open movement. So actually they themselves were told on the one hand to stay at home, movement outside the home was discouraged. And when, let's say, a contraceptive or abortion need is seen as not absolutely essential to actually go out and embrace the virus as it was seen. Then, and in addition, the loss of livelihoods, which prevented ability to pay for many of these services, these were in combination. There's a huge demand aspect to the whole thing. And what we saw were a lot of studies coming out, but they were really based on impressions and on modeling, and they were very useful at the time. Of course, Guttmacher, UNICEF, WHO, they had huge impacts. But now I think we have the benefit of looking at the real evidence. What were the short-term effects? We can look back 1.5, 2 years and see what they are. And that is what the session is about. And I have the pleasure of introducing to you our first panelists, Mr. Saad Abdul Mumin. He's an MD, an MPH, and a PhD, and is a seasoned epidemiologist with extensive expertise in epidemic management. He has really been working on COVID directly, as he has been working on SRH, family planning, HIV implementation research, data and analytics, including monitoring and evaluation. So he's a perfect candidate for our main keynote presentation. He's published in numerous peer-reviewed articles and presented in many international conferences, and he is most importantly Deputy Editor-Chief to Global Health Science and Practice Journal. He's, I know, in transitioning to a new and important role at the Gates Foundation. This work was done prior to his transitioning, and he's presenting results from a scoping review of evidence that really covers what was done. So he's going to introduce us through. And he's one of his co-authors on the study was Anne Biddlecombe. She's a co-author on the scoping review, but after his presentation, she'll initiate the discussion. Anne Biddlecombe received her PhD in sociology and pop studies in 1994. Her research interests are in sexual and reproductive health and behavior. She worked at the Population Council. I knew her as a young researcher in the 90s, and then she went on to head the fertility and family planning section at the UN POP division. And now she's the director of international research at the Guttmacher Institute. We're really lucky to have both of these speakers, and they will speak, and then we'll open it up for open discussions. So over to you, Saad Abdul Mumin, for your presentation, please. Thank you.
Yeah, thank you, Ziva. Thank you so much for that kind introduction. Maybe I will start by saying I'm here as an independent expert, and I'm not representing any of my employers at this point, but I think we have a recorded session that Anne will play so that we don't have issues with the connectivity bandwidth issues. So Anne, if you are ready, please put on the recorded presentation, and we're here to take on any further discussion as we play the presentation, or when we have difficulties, we can make clarification. Over to you, Anne.
Sure, thank you. And let me know if, I just want to make host disabled participant screen sharing. So our first tech challenge. Tanjo, could you please enable me to share my screen?
Sure thing.
Thank you. Okay, 1 second here. One second.
Audio. I don't think there is audio on.
Yeah, audio. Maybe you can talk us through this, Saad, then, in that case.
Yeah, sure. And So thank you so much for the opportunity to be part of this important session. And I appreciate the opportunity to share some key insights from a scoping review on the impacts of COVID-19 on contraceptive and abortion services in low and middle income countries. And I'm speaking as a co-author from a larger group of colleagues listed here, and also as an independent capacity, as I've mentioned earlier. Can we go to the next slide?
Yes, 1 second, Saad, let me queue up the slides instead of the video. If I could just have everyone's patience for 5 seconds, okay?
Sounds
Sure.
good.
Yeah, good. Just to fill the time, I want all participants who've joined today to think about, we would really like to make this very interactive when Saad ends, and to hear your experience about your research, any suggestions going forward. I think that's what IUCSP would really benefit from this session. So I want to use up every minute, and for you to, while you're waiting, to think up questions you'd like IUCSP to pose in the next couple of years as well. Here we are. Okay.
Yeah, thank you. Thank you, Anne, for all the being the tech expert here now. Yeah, so we can go to the next slide. And in this presentation on COVID-19 impacts on essential sexual and reproductive health services, I will focus mainly on trying to respond to 3 questions on what do we already know, and what does the evidence show, and of course the implication of our new findings to the to SRH services based on the findings from our scoping review. So we can go to the next slide. So regarding what we already know is the first, we know that infectious disease outbreaks can affect the demand for, provision of, and access to sexual and reproductive health services, including contraception, abortion, and post-abortion care. For example, if we could recall during the Ebola epidemic, moderate declines of about 6% in the use of family planning occurred in Sierra Leone, but we noted dramatic changes or declines in Liberia of about 65% and 52% decline in access to contraceptive services and abortion services in Guinea. Second, we also know that COVID-19 presented unprecedented challenges to meeting the reproductive health needs of people in low and middle income countries, but there is no comprehensive synthesis of the nature and range of empirical evidence on its impact on contraception and abortion-related services. And we also know that there are a range of model-based estimates that really started work early in the pandemic. However, we are short of empirical evidence over time on what is actually happening on the ground. And we think that a synthesis of existing empirical evidence could inform updates to model-based estimates and scenarios of the magnitude of impact of COVID-19 on sexual and reproductive health, especially in low and middle income countries, as Ziba mentioned, that some of the fragile settings or countries with fragile health system will bear the brunt the most. We can go to the next slide. So in our review, we conducted this year a scoping review to identify, map, and synthesize studies in low and middle income countries that measure the impact of COVID-19 on demand for, provision of, and access to contraceptive and abortion services and reproductive health outcomes of these impacts. We developed a protocol and a priori before we began the scoping review, and this protocol was registered in February on the Open Science Framework, and you can see the link to the registration on this slide. Using a we searched bibliographic databases from December 2019 to February 2021, and gray literature sources also from December 2019 to April 2021 to identify and extract relevant information related to our inclusion criteria for this scoping review. Of 1,812 unique references that we identified via our electronic bibliographic databases, in addition to 68 unique full text documents identified via our Gray literature, we ultimately included 71 studies in this scoping review. We can go to the next slide. So looking at the nature of the evidence that we identified, of 71 studies included in this review, the majority, about 61%, were not peer-reviewed. This indicates the predominant role of Gray literature and preprints as a source for early empirical data on COVID-19 impacts on SRH services. And most of the studies were primarily situated in Africa, accounting for about 30 studies, and mainly from Eastern Africa. And Asia also accounted for about 25% of the studies included in this review. Now looking at the timelines of evidence, we can go to the next slide. Yeah, in this slide, we can see the bar that shows that 40 of the 67 studies with known dates of data collection were based on data collected from June 2020 or earlier. Thus, our findings largely reflects evidence from the start of the COVID-19 pandemics in low and middle income countries, as most countries began to have the full brunt of the pandemic from March down to those earlier parts of the year, at least to the middle half of the year. So most of our studies or data that shared on this or analyzed on this scoping review were from that period, June 2020 or earlier than that. So indicating that this is mostly the early part of the pandemic in most countries that we included in this scoping review. Next slide. So now quickly, let me attempt to summarize 71 widely varying studies in a short set of summary points, just to show the evidence. Regarding contraceptive services, most studies, 38 of 55, involved cross-sectional or longitudinal surveys, and many were conducted online or by phone due to pandemic situation, and 19 studies used administrative data. The magnitude of need for and access to contraceptive services varied widely by study settings and populations represented in these studies. And nearly all of the 10 studies on changes over time in contraceptive service provision noted declines of varying magnitude, but severe disruptions were relatively uncommon or of limited duration, as reported in most of the studies. Most relevant studies found declines in at least some indicators to access to contraceptive services during the COVID-19 within the study period. Among 17 studies with population-based data on contraceptive use and change, including method starting, method stopping, and switching, and also the changes over time during the pandemic, results were mixed by setting. Of the 10 studies assessing changes over time to contraceptive service provision, most noted declines of varying magnitude, though according to administrative data that we analyzed in this scoping review and also health provider records, severe disruptions were relatively uncommon or of limited duration. Most studies assessing access to contraceptive services found declines in at least some indicators, though 7 of 8 longitudinal studies of individual contraceptive use outcomes found that most people tended to sustain their existing contraceptive behaviors. Now, quickly looking at abortion, also based on the nature of available data, demand for and provision of services, need for and access to services, and change over time, as well as the use of services and outcomes. 26 studies included empirical data on abortion and PAC services, with the majority using administrative data accounting for about 54%, and a smaller proportion using online surveys of key informants accounting 19%, or individuals accounting for about 15% of these studies. Only 6 studies addressed demand for abortion or PAC services, including major barriers to seeking abortion. 11 studies show evidence of impact of the COVID-19 pandemic on the provision of abortion-related services, with 10 studies on abortion and 2 on PAC, post-abortion care services, including the level of and disruption in service provision. the degree to which programs adapted provision to facilitate client access, and the level of shortages in safe abortion supplies. Among the 8 studies with data on access to abortion services, including one that also had data on post-abortion care, 2 had services on perceived declines in access to surgical and medical abortion compared to pre-pandemic levels. They were about the potential or actual impact on the abortion safety, and 6 studies addressed barriers in accessing abortion or post-abortion care. There was more empirical evidence on use of abortion, with 16 studies, 7 of which included post-abortion care. And most studies showed declines in abortions during the COVID-19 pandemic, with variations by geography, source of data, gestational age, and type of abortion, that is either medical abortion or surgical abortion. There was no systemic pattern on the direction of impact on post-abortion outcomes among the 7 relevant studies included in this review, possibly due to 2 opposing factors at play: an increase in barriers accessing PAC on one hand, and the increase in numbers of people seeking post-abortion care because of an increase on a safe abortion on the other hand. Next slide, yeah. So quickly, regarding the implications of this scoping review, our data indicated there is depth of data on pandemic's impact on certain regions, especially Latin America and the Caribbean, and across the full range of sources for contraceptive abortion and post-abortion care services, including both public and private sectors. These gaps in geographic representation and full range of service sources complicates interpretation of existing data. And study data tended to represent part of, not the complete picture in a country, such as data from a single health facility, or we saw data from the public sector only, or data focused on a particular program provider, or data at one point in time. Thus, it is difficult to interpret reported changes during the COVID-19 pandemic, as information is missing on the degree to which people may be obtaining services from other sources, either from pharmacies or data or services, including new or adapted sources to improve access during the pandemic, for example, telehealth or self-care. And one important gap is that studies are especially lacking on how the pandemic has affected SRH of vulnerable population, for example, data on adolescents, people living with disabilities, and displaced people and refugees. It is important to note that while the impetus to collect data quickly and in the context of a pandemic likely led to preponderance of studies based on convenient samples, online or mobile phone surveys, or interviews with key informants, these approaches can result in relatively selective representation of the impact of the COVID-19 pandemic without giving us a full picture or generalizable data across board. Finally, we think that empirical data are needed on the pandemic's longer impact on access to essential SRH services that are representative of the population being studied, and data that assess trends in demand, provision, access, and outcomes. Next slide. So I would like to acknowledge the generous investment in the work that I've presented so far, from contributions from an expert advisory group here who represent expertise from major SRH service delivery organizations in low and middle income countries, and international bodies engaged in reproductive health monitoring and guidance, and the generous support from several donors. And especially thank you for the opportunity to share these findings with you. And thank you to Ziba for being chair for this session. We welcome comments and questions, and my colleague Anne will respond. Thank you.
Thank you very much, Saad. And despite all our glitches, I think we did wonderfully. It's all very clear, your presentation. And I invite Anne, because she's, she's a co-author on this study, and also perhaps will throw a little bit more light on elaborate on some of the findings. So over to you, Anne.
Thank you, Zeba. I wanted to underscore a couple points that Saad raised in the presentation of evidence. And And the first is with respect to model-based estimates, and they're as good as the assumptions that they make and the input data that they're based on. And back in March 2020, colleagues at the Guttmacher Institute, we generated estimates of the potential impact that COVID-related lockdowns, supply chain problems, et cetera, might have on a set of really core reproductive health outcomes. And we were using, I would say, relatively simple assumptions at the time, based in part, informed in part from prior infectious outbreaks and epidemics. And this is given that we were literally at the very start of the pandemic. And the assumption was of a 10% proportion reduction in contraceptive use from pre-pandemic country-specific situations. And I think the scoping review really highlights the critical importance of on-the-ground data. As Saad noted, given all of the whole research community was particularly challenged with respect to gathering real-time data in ways that, we were facing many things, lockdowns, et cetera. And so I think it shows a gap and the important role that administrative or health management information systems kind of data, longitudinal data, the critical role that those kind of data sources have for disentangling what is really attributable to the pandemic versus longer term trends or seasonal changes, et cetera. Second point is that this scoping review represents data, as Saad showed, data that were collected for the most part, from around mid-2020 and before. And here we are in Omicron times, and it seems that the word of the past couple of years is evolve. And so open questions continue. It's hard to say what phase a country is in vis-a-vis the impacts of this pandemic. And so, for example, the study findings that we were looking at from across the 71 studies, they're from an initial lockdown and travel restrictions in countries that may reflect a service environment that was still able to draw on existing stockpiles of essential commodities and supplies. And the last point that I wanted to raise was with respect to the partialness of the picture. And this again was a point that Saad underscored. So the scoping review evidence, we tried our best to synthesize what we could see from across the 71 studies. And at the same time, we have to acknowledge that each study unto itself gave a picture of the public sector or reports from major private or NGO health providers, or population-based data that showed you demand or use. But each of those is a particular slice. So, for example, this is from the evidence on abortion and post-abortion care. And this is my last point, and then I'll be quiet. So for example, despite misoprostol and medication abortion being included in the search terms, we found no evidence regarding impacts of the pandemic on access to these effective medications from other sources, such as pharmacies or informal drug sellers. And so, and also with data mainly from health facilities rather than population-based data or from part of the health system, we thus have a limited understanding of what role pharmacies or self-managed abortion using misoprostol or combined medication abortion obtained from informal sources might have. So in terms of substitutions that people were able to make or not make. And so I just wanted to underscore those kind of three overarching points. And I know that I was kind of glancing at some of the colleagues who joined us in this session and who I know have really relevant work and experiences that they may want to share, as we all, I think, in the research community worldwide really struggle to document the many ways that this pandemic has affected the health of people worldwide. Thanks.
Thank you very much, Anne. And now we're actually good for time, and we'd really love to hear more. As you said, there are real experts. I've read most, I mean, a lot of people have contributed probably to studies that you've included, and it would really serve sort of science if they gave their, you know, their perspectives on what Saad Abdul Momen presented, and also their own perspectives of how you know, we as demographers, public health people should really be, what should we be focusing on? I mean, should we be trying to improve health systems data to capture, because it's not just COVID. I was just reading about some projection, I think by the WHO, if I'm not mistaken, saying, well, the next pandemic is going to be even worse than COVID. I mean, you know, God, so on basis of what? So I think, let's say if that were to happen, let's be prepared going forward so we are able to capture data better. Is it purely through public health systems? Should they be including more from the private sector? You mentioned an informal sector. I mean, should we have different systems? Because I can't see us in days of COVID going out and doing quick surveys. I mean, that's really very, very difficult to do. I mean, so we should have things that, you know, actually happen on the ground. And I totally reinforce what you're saying about the importance of grounded data, because the timing of the infection, the pandemic, the spikes, the lockdowns, etc., are totally different in individual countries. And that is a challenge for modeling. But then there is value to modeling. You get some big figure that everyone pays attention to. So the floor is open. Please raise your hand and chime in. The more discussion, the better from everyone's point of view. So please go ahead. First, we could start by addressing questions to the two panelists, if you like. So if I don't see a hand up, let me ask a question to Saad and to Anne. I think you did actually answer it, but in ways, I think we talked more about a question of abortions, maybe abortion-related services, or maybe I was kind of not that listening that carefully when you initially talked about contraceptive services. And does it make a difference? You know, legally, I mean, legally and administratively, contraceptive services are more a part of the regular health system, whereas with abortion services in many settings, they're not part of the regular health system. They're either provided by private sector provided or they're under post-abortion care. I'm not saying everywhere, but it's a mixture. Whereas I think contraceptive services are generally, maybe, I don't know, with the exception of the US and some, but for LMICs generally provided by the public health sector. So do you see any differences in how we captured disruptions in contraceptive services versus abortion services? Which is more difficult to study, which is better to capture, easier to capture? You smile. I hope you're not smiling at someone else. Huh?
Yeah, and do you want to take that?
Well, I think I can speak to, at least from the evidence that we saw, that what's out there is that there's much more that speaks to the impacts and the different dimensions that we looked at with respect to demand, provision, access, and then the outcomes from that. There's much more evidence out there on contraception, both from, you know, what people were reporting, however they were surveyed, and also from what the like member associations were reporting, or ministries of health, with respect to services and problems, provision problems that they had. And abortion, there was much less, there was not a lot on abortion related services, induced or post-abortion care. And what we had quite a bit was on from a service perspective, and of course, as you, Zeba, know, and a number of colleagues who I think are attending here, understanding what's happening, especially in highly constricted environments with respect to induced abortion, it's even without a pandemic, it's extraordinarily challenging to understand truly what's going on outside of the formal health sector.
Thank you. Emily, would you like to ask your question in person? I mean, you've typed it up, but if you just ask it, it would be great. If you unmute yourself. I have two questions. Yeah. So maybe Emily, I think Emily's reluctant, so I'll go ahead. She says it's great learning, and she'd like to see if you have experience of any method shifting from permanent to spacing methods as an impact of COVID. Either one of you, go ahead, chime in with answers. Sad, would you like to?
Yes, I don't think there is a systemic pattern on the changes also on method choice, and also the preponderance of other methods in the studies we reviewed. But Andy, you want to say more on that?
Sure. Again, Emily, thank you for that question. And it points to, again, the limited data that we have, because these were, for the most part, on the method switching. There were a number of surveys that asked about it and examined it. And there's, as Saad said, there's no kind of across the board systematic pattern in one direction, like from going from short acting to longer acting methods. There's a lot there, but not enough to be able to give a pithy across the board overall, this is where it landed.
I think what you underscored really was the patchiness of it all. There's nothing on the basis of which you can really generalize. But I think 2 years from now, probably we'll have much better. Emily says she can't unmute, and I wondered if Tanjok can help us with that. You know, it would be nice to hear the voices of panelists. Like the conference participant, I'm not sure it's a man or a woman, but they say, if you can unmute, please ask your question. Otherwise, I'll wait for 1 second. And it sounds like people can't unmute. So I'll ask, if women cannot access contraception as before, does that lead to increased use of abortion? Good question.
I think it's a possibility, but that we can conclude from the available data that we have. But we think that possibly, of course, due to the opposing factors that I have mentioned in my presentation, that it's unlikely due to disruption in services, though the disruption we've seen in our data were of short duration, and there were no severe disruption. But that is really a possibility that women who are unable to access contraceptive services may likely have unintended pregnancies and ultimately unsafe abortion, and that may have impact on the safe abortion or post-abortion care to women who are unable to access contraception. But I don't think we can conclude with certainty from the data that we have synthesized, but still I'm open to your additional comments on this.
I think I appreciate that point, because it also underscores the fact that with abortion, post-abortion related care too, is that these are timely. These are not like elective and I can postpone it for 3 or 4 or 5 or 6 months. So it just underscores the kind of critical and essential nature of both contraceptive and abortion related services.
Thank you. We have Susanna has her hand up. I hope she can unmute. Susanna, go ahead. I think I don't hear her voice. I think there is a general Again, I plead to Tanjo, if you could unmute our participants, please. I think there's a general sort of embargo against them speaking. If not, Susanna, could you write your question in, please? I know it's a bit of hassle, but I don't know what the unmute, what do we do?
I think I've given access to Susanna.
I was muted.
Yeah.
Oh,
Okay. Go ahead,
okay.
Susanna.
Okay. Thank you very much. Thank you very much for this interesting session. I think this is some place we are going to be in the next years, trying to find out what are the consequences of the pandemic on the access of contraception and abortion. So I think I have a million dollar question here for Anne or someone else who could try to answer that. We are carrying out a survey in the next year, sexual and reproductive health survey. So do you have questions that should be asked in a way that we can capture changes in abortion or contraceptive access during the pandemic, hoping that by 2022, the pandemic is over or almost over? So how we would look back and have some questions on a household survey to see if that people had changed in some ways or had problems of access. There are some places, people that are already doing this kind of surveys. Over to you.
Yeah, that's a really good question for all of us who now will be focusing on capturing this experience. Anne?
I would say in general, and this is again based on and looking what's available and what's been published thus far, is that you'd want to ensure that the questions you ask are multidimensional, are capturing kind of the process, are capturing these distinct dimensions around demand, around perceptions of, around access, and around use, in order to give that fuller picture of these kind of interlocking parts of people's lives that ultimately result in these kind of critical outcomes that we're all looking at. I think the challenge with a survey, and this is what we noted in general around the existing evidence, is that the questions in a point in time are then kind of retrospective, or asking people to think about asking them directly how the pandemic or aspects of it affected them, as opposed to, and this may be just drawing on other sources of data in the analysis that follows to corroborate or round out the fuller picture of change over time. This is where I think personally that some of the studies that have used the HMIS data over time really help us understand more accurately the magnitude of impact, because you're able to disentangle or tease apart what are often time varying seasonal influences in people's behaviors. Saad, do you have, or Zeba, anything else to add? I'll also not a shout out to the PMA surveys that did do a pretty robust effort, make a pretty robust effort, a large scale effort at assessing impact in a household-based survey.
No, I think you've said, go ahead. No, just to add a comment again around timeline, is also important when you put in your survey questions. If you're capturing either in the last 12 months or in the last 24 months, given that now we have the pandemic for nearly 2 years, and we really don't know as the situation continue to evolve. So perhaps putting some guardrail around timeline may also be helpful to understand the data that we are capturing in terms of the impact of the pandemic on SRH services when you do a household one-shot cross-sectional survey. But again, I agree that the PMA data, longitudinal data was very helpful. And perhaps as we continued to collect data or to understand the impact of the pandemic, it might be helpful to consider a longitudinal approach rather than a cross-sectional survey. That might be expensive, but having that panel of longitudinal data for a larger surveys might be very helpful to understand or have a better understanding of the picture of the impact of the pandemic. And to your point, Ziba, regarding the strengthening the HMIS, I think this underscores the need for countries and also for donors and other agencies to really strengthen the HMIS system so that we can continue as pandemic evolve, because the world will continue to see pandemic. This unfortunately may not be the end, and even the pandemic currently we're experiencing, we don't really have a clearer picture to the end of this pandemic. So perhaps part of the health system strengthening approach is to really strengthen the HMIS system to be able to capture that data and give us that picture. Because what we saw in the early part of the pandemic is a knee-jerk reaction. All systems collapsed or closed down, and there was no definition of essential services until maybe over time as the pandemic evolved, as everyone does not really understand what the pandemic looks like. So perhaps when we prepare and strengthen systems, I think it's about looking at pandemic generally, not just the COVID-19 or perhaps emergencies, because we have pandemic might be part of the emergency response that countries or health system strengthening will really factor in as we build systems. Over.
Yeah, and climate events, I just want to throw that. I mean, they can really disrupt political and climate events, disrupt services, not just pandemics. Emily has a specific, you know, I guess she can again not, are you now on unmute or should I? Okay, I'll just read her suggestion.
Yeah,
There
Jeba,
you
this
are.
is
Go ahead.
Emily. I'm able
Yeah.
to unmute this time. Thank you so much. It
Okay.
was a very fascinating session, in fact, of my choice. Yeah, just answering or just to understand what's exactly in terms of, you know, using a contraceptive calendar method for understanding the use and access of contraceptive. I mean, how about that experience of using during the COVID period, if we can just do that in terms of understanding how the women have actually used or there is a shifting of using the methods. And then when we're actually comparing, you know, any survey or the government HMIS data, as I mean, that's really very important at the time.
And I'll pass this to you.
Yeah, I think she's muted again. Could you unmute again, please? Emily?
Oh, I'm sorry.
Yeah.
I'm sorry.
Yeah.
Yeah. So what we are seeing here is a shifting from a permanent method to a, you know, to a temporary methods where government, the entire public sector data that's showing in some of the very populated city in India, districts or states in India. So I think that's very important at the time to understand an impact of COVID. Just wanted to say that. Thank you so much, Eva.
Yeah, thank you. Thanks. I think that we accept, I mean, that's really a good suggestion about the contraceptive calendar, but I think we need more. I mean, it's like capturing the whole experience, but certainly where there's a survey about to be launched and definitely collecting the contraceptive data. We're really talking about contraceptive right now, continuation, not so much about abortion, which seems like even more difficult a challenge to capture. So Susanna, you have your, would you like to comment on the contraceptive calendar idea, Anne, or Saad, or?
I would just say it was to applaud the early data efforts that were part of the studies that were in the scoping review, where you know, you have to be adaptable. There are more complex data collection mechanisms like a calendar, but I wanted to applaud the data collection that did happen and where you were working with, you know, via phone or other ways where some of these more complex mechanisms are not so possible or just much more challenging to administer. But I did also want to nod out to Susanna with respect to the data. This was in the scoping review. It was one of the limitations in that there weren't so many studies that that were included here, despite the search, from Latin America and the Caribbean, that area, and certainly in South America has been extraordinarily hard hit by COVID. And so I think that's a place where lifting up other evidence from the region is really a priority.
Yeah, just to add one point again, as we continue to collect empirical data, I think it's the perspective of the service providers. I think we need to also understand the impact of the pandemic on the service providers. That will ultimately also have impact on the care they provide. As we know that early part of the pandemic, some of the healthcare providers were deployed to provide services to COVID, to support the COVID-19 response, and so that will continue. And also the really work-life balance of the service providers as they continue to participate in the COVID-19 response, the mental health implications, and also ultimately the dropout that we begin to see, that some healthcare workers are also do not want to practice health service provision. So I think we need to also collect that data to have to triangulate all these findings from both the clients and also the service providers and also the system data to understand a clearer picture of the impact of the pandemic overall.
I think that's absolutely it. I mean, without those three sets of perspectives, the systems, the healthcare providers themselves, and the clients. And I was saying that the best to me for us, were the solutions of tagging on. If you had a panel that you'd interviewed, maybe for quite a different reason, but to be able to go back to them because you already had their trust, you had maybe their phone numbers, you could do telephonic things. So that seems an opportunity. But longitudinal data, if we can maintain that, it's really, really helpful. Susanna, do you have a new hand up? We would welcome a new question from you. Yeah, please.
Yeah, sorry. Yeah, no, sorry. It's just because I mentioned Latin America, and I think would be very important to know more. And we have few studies here. But the sense we have here in Latin America, we are different for some reasons. One is the permanent. We have a lot of people using permanent contraception. The female sterilization in some parts, and some male, but very few, but IUD in some countries, and that makes a difference of the pandemic. The lockdowns is short, but not the whole pandemic, but the lockdown time. The other thing that it's kind of different here, in most of the countries, we can get contraception, continuous contraception over the counter on the pharmacy. We don't need to have prescription in most of the countries to get those. So maybe that made a difference in access. But that brings something else, that is inequality. People who can buy in the pharmacies, they may not have been the shortage of methods, but the poorest may suffer more. So it's very important that in the next years we can just look at these particularities of Latin American and make sure that in any other instances we can make sure everyone can have access to whatever method they are using, or even abortion access. Over to you.
Thank you. And would you just like to comment on Latin America? Or?
Nope, I was just taking a couple notes to remember from what Susanna was raising up. Really important.
Really. It was more like a comment and additional information, which is so useful for all of us. We're all learning. I mean, it's such a, I think in ways that you got 71 solid studies, that in itself over 2-year period is pretty impressive. And that so many people came out and really felt like you all wanted to contribute somehow to the response. And I think as researchers, the community has really stepped out and maybe experimented with things that they wouldn't have otherwise. So I think it's pretty impressive what people have done. But as things settle down, I hope they settle down, or as things normalize, I think there are new questions that are coming up. I just wanted to bring up the fact that sometimes the medium long-term impact might be actually an improvement in my own setting, I can only speak to that, maybe there are solutions like you mentioned, Saad, telehealth and self-care. They were really not entertained earlier because the health system was so like powerful. I mean, we are not going to go in for these solutions. But, people who live in remote areas, particularly women who have limited mobility, they benefited by suddenly a proliferation of health lines and doctors who were operating remotely. So there is an improvement. I mean, it remains to be seen whether that remains a pattern, but innovations that actually will stay. To me, it's like people now entertain those much more. And similarly with the health systems data or data in general, I think people will be more attentive to data needs because you needed them for the lockdowns, where is the pandemic hitting people most adversely, where to do the lockdowns, especially if they were selective and so on. So I think that in the medium, when we have the session 2 years from now, I think it's going to be maybe asking more questions. And I think there's going to be a realization that this has had, the pandemic has had a profound impact on how we do things, how we deliver services, and how we collect data. But let me again ask if there are any more questions from our really, I see a who's who in our list of participants, and we'd love to hear anything more. Anne, I know you participated in studies. Elizabeth, anyone want to comment? If not, I hear somebody unmuting.
No, it's Saad. I just want to thank
Saad,
you again,
okay.
and really, as our colleagues continue to collect data, just to underscore the point on need for trend and also emphasis on outcomes, and so that will be really very helpful as we continue to assess the impact of the pandemic over time. And
Sure.
this is a great
and if it's a
session.
continuous trend, or how consistent it is, and so on. So then I will. Yes, please go ahead.
Stan Becker, Baltimore. What would you add to the PMA questionnaire to get at things that you've discussed this morning better? Thank you.
Wow, that's a nice open invitation, Saad and Anne. From Stan, who of course is at Johns Hopkins, where they do the PMA. Anne.
Lamentably, Stan, I do not have my top 3 in the back pocket set of questions, and I would just go back one to applaud PMA's rapid effort at providing early data, frankly, and with attentive to taking advantage of a longitudinal setup, which is really important. And I would just go back to the overarching point I made with respect to a similar question that Susanna raised, which would be a critical eye again at ensuring that kind of distinct dimensions and elements around use, around demand, around access are reflected.
Quickly to add, if the PMA data is amenable to getting the perspective of the service providers, I think that will also be helpful to consider.
And Stan, you do collect data in clinics, so I think that wouldn't be so very difficult. I think you do interviews with providers. Isn't that correct?
As far as I know, I haven't been involved in this latest round, but certainly earlier rounds, and I think they're continuing. Thank you.
Okay, thanks. We'd also like to know, I guess, just throwing in my bit, it's just not, how many clinics actually had to shut down or temporarily close down and so on. Looking at the resilience of the health system with the public and private, and of course differentiating between them because you have the longitudinal data. I suspect some of them actually had to close down for a while because of the lack of healthcare providers, so. But anyway, it'll be interesting. I think that's a wealth of information only because it's longitudinal. I don't want to leave any one out because, even if you have just a comment, anything, it doesn't have to be but not to leave the perspective of the people who joined today. And because if not, I don't see any hands up as such. I would like to thank Saad, Abdul Momin, and Anne Biddlecombe for sparking off the discussion, for giving us that overview of the overview of the overview of the excellent 71 studies that you shortlisted, systematic review, and also the inputs of all our participants today. I think we're all kind of stimulated to go forth and do more research on that. We will all encounter the same issues of dearth of data, but I think we can influence data, just as Stan's last comment. What would you do differently with PMA? Would you do things differently with the next round of DHSs as well? So, and in tagging on some of our questions to ongoing longitudinal data in our various country settings where we work, I think is an excellent opportunity. So I thank you all for this session. I know there are multiple choices of sessions to attend at the same point. That's the problem with these very, very rich programs that we're seeing in that IUCSP is offering. So thank you for attending today, and really look forward to catching up with others, familiar faces on other sessions. Thank you all very much. Good night. Oh, sorry. Yeah, Susanna, we should also look at birth data. That's right. That was a big news item here when UNICEF published a study about, I don't know, 200,000 additional births to happen in Pakistan, and everyone went crazy. And actually, it wasn't news because 200,000 births do occur in 6 months or every month or something like that. So, to differentiate what is news and not news. But when so I think the birth data is very important because it has huge impact. In other settings, I'm sure they're more responsible. Would you like to make a comment on that, Susanna, before I close? Or
Well, yeah, thank you very much. Sorry for
yeah, it's okay.
making so many comments. Yeah. Now it's because we are in the beginning, we were, some people were thinking that we would have a lot of births after 9 months of the pandemic because people were in a lockdown. And this didn't happen in most of the countries in Latin America. I'm not sure if that is the same in Africa, but here, if people had hard access to contraception, they did have access to abortion, because if they were at home and got pregnant, the birth didn't happen because we have smaller numbers of birth than expected from the previous trend. So that may be something we should look at together, birth, contraception, and abortion, to see what had changed and what were the shortcuts there.
Thank you. I actually want to take the advantage of, I see Vladimira Kantrova is online, and whether the POP division is taking on something like this, because I know that they're really excellent at the models that they've been producing, and whether something like this is on the cards that we can look forward to. Sorry to put you on the spot, but you can say yes or no, or elaborate, Vladimira. Perhaps Vladimira doesn't want to at this point. In that case, oh, okay, go ahead.
Yeah, sorry, I was trying to find an unmute button, so apologies for that. So we are currently working on the new revision of the World Population Prospects 2022, which will be published next year, either Q1 or Q2. And of course, like for all countries, we are trying to look at the evidence which we see from the data currently. And it's much easier, of course, in the countries where we have the data, like voter registration systems. So I think in these countries, we will definitely reflect the potential impact of COVID pandemic. It's less so possible at this moment in the other countries. So it's, but we are considering, and if the data are becoming available, we will also include them in that impact. So that's from me.
Thank you. Yeah, no, thank you. That's something to look forward to. And I think your models take into account both surveys and registration, so it should be interesting. Looking forward to that publication. Again, if there are no more questions, I don't want to keep you from jumping into other sessions. I thank, again, I thank Anne and Saad for stimulating this discussion, for all of you for joining, and have a wonderful conference. I know it's just the first day, but do encourage you to attend as many sessions as you can. Thank you very much. Good night from me.
Thank you so much, Seba.
Thank you.
Thank you.
Thank you, everyone.
Bye.
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 Namaste to
Bye.
all.
Yeah, namaste. If you were there in person, it would be wonderful. Bye-bye. Bye.
Bye-bye.